important from medicine perspective when it comes to stroke is when the first time a patient is alerted as a stroke alert, the goal of treatment is hyperacute management of stroke to salvage the potential tissue, and it's not to identify the etiology at that time. So that's what your stroke fellows are doing at that time. By the time we've done everything, he's beyond the window after 24 hours, that's when you're trying to identify the etiology, because that will change long-term management, right? That is the time we're trying to find if this is out of one of these 5, what type of ischemic stroke it is at the end of the day. The second thing that comes down to is the DAPT duration. So once you know it's an ischemic stroke, no matter what the etiology is, you start them on DAPT for 21 days. So you can start doing that as soon as they come out of the stroke unit, because you know it's not a hemorrhagic stroke, so it's some sort of ischemic stroke. You start them on DAPT for 21 days. But I'm sure a lot of medicine folks come and see those notes, like sometimes it's 21 days, sometimes it's 90 days. What is happening? Like, why is it 90 days sometimes? So essentially, once you know that the etiology of stroke is large vessel disease specifically, then the trials show 90 days of DAPT is great. But now the point is, defining what the etiology is not part of hyperacute stroke management, it's part of the medicine team. But if you somehow end up seeing on the CTA, coincidentally, that this person has large vessel disease, so your neuro folks end up just giving 90-day DAPT, because you will ultimately change it to 90 days. So when you receive the patient, sometimes you see 21 days, sometimes you see 90 days. So I like to not think of it as 21-day DAPT versus 90-day DAPT. I like to think of it as 21-day DAPT that stayed 21-day versus 21-day DAPT that became 90-day DAPT. Does that make sense? The other thing that I think is important in this case is, why are we trying to be so aggressive in trying to find a cardioembolic origin? Like, why are we trying to give a loop recorder when we did not see anything? So I like to think of a small vessel disease as a chihuahua, a large vessel disease as a beagle, and a cardioembolic etiology as a Great Dane. So that's the risk of a recurrent stroke. If you have a small vessel disease, you'll have some risk. So you put them on DAPT for 21 days irrespective, as part of any other ischemic stroke workup. If you have someone who has a large vessel disease, the risk is enough that you want to put them on DAPT for 90 days. But if someone has a cardioembolic source, and if you find AFib, the risk is so high that you can almost guarantee this person's going to have stroke again. So I don't even want to start them on DAPT, I want to start them on anticoagulation. That's the amount of difference it makes in management. So I'm trying to push myself harder, like, if there's some suspicion in terms of, like we showed the size, that this might be cardioembolic, I want to be so aggressive in trying to find an embolic source for the same. Does that make sense? And that's why like cards and neurology interrelates. And the last fun thing that we talked about when I was like, initially the first patient came with a lot of slowness, and he had, the reason we do stroke labs, and which includes TSH, is because this person was severely hypothyroid, almost in hypothyroid storm. Like not storm, like hypothyroid coma. So we started working on that. Essentially how it came about, the deficits that improved, the non-focal deficits, are explained by the hypothyroid state, but he at the same time ended up having a stroke. So the deficits that never improved were potentially explained by stroke. So you don't anchor yourself that there's only one thing that's happening. You want to simultaneously treat them both and explain the same thing to the patient. So yeah.
Thank you guys.